Thank you very much to Dr. Virani and Dr. Morris for inviting me to give this talk. And to some degree, I'm not sure how I feel about going first, but that's, I guess we need to sort of see how this will go. This is, I think, was very challenging to come up with the top 3 presentations. So what I plan to do is give you a little bit of information about some of the other studies that were presented and then highlight the 3 presentations that I thought may be very impactful down the road. So these are my disclosures. And so I think hypertension was really spotlighted here during the ACC 2018. There were about 50 hypertension posters, lectures, and debates. We, in fact, had 2 great late-breaking clinical trials this morning, which made my work harder, Pam, including the Black Barbershop study and the Triumph study, which were held this morning. And then we also had a session in this room a few days ago that reviewed the hypertension guidelines, and we were honored to have Dr. Welton, the chair of the writing committee, as well as other members participating. So some of the interesting tidbits, and I think this is something that I will probably take back when I go back to Seattle. So there was a study that was presented that looked at yoga's effect on blood pressure. And what I thought was interesting is that they separated out the different parts of yoga. So there's deep breathing, there's stretching and relaxation. And they found about a modest 10% reduction in blood pressure. But when they separate out the components, it turns out that deep breathing yielded the greatest benefit, stretching had a modest benefit, but relaxation really didn't do anything. So when somebody tells you to relax, I'm not sure that's really going to be that helpful. The other thing that I thought was pretty funny, so this caught my eye. So there's a gene called INDY, and INDY stands for I'm not dead yet. And so I was like, what was that? That's fascinating. So I went to talk to the author down at the poster sessions. And so this gene has been found to be associated with longevity. So when you have a decreased amount of this particular gene, you live longer in animal models. And the great thing about this is that if you have lower amounts of this gene present, it seems to promote good health and longevity, even if you eat a normal amount of food. So when they're fed normal diets, so not putting them on low-fat diets or anything like that, just regular diets, they actually still live longer. So somehow this particular gene is regulated through stimulation of catecholamine pathways, but is potentially an opportunity for living longer without sacrificing what we like to eat. Yeah, I will preface that, we're having hypertension talk, but the point being, I think there's opportunities there. There were a lot of trials on SPRINT. Many post-hoc analyses were conducted and posters were presented. There was, one study that looked at patients with cardiovascular disease. They reviewed sort of the benefit specifically in that high-risk population, and in their analysis, they didn't find a clear statistical benefit to lowering blood pressures and were worried a little bit about higher serious adverse events that were seen in that population. And another study looked at a low Framingham risk scores that they calculated for the patients at less than 10%. They seemed to be having higher event rates. And I think, as you may have seen in JACC last week, there was an article that looked at sort of trying to stratify patients into different risk categories using the current the ASCVD risk score, also showing that maybe when you do a risk sort of benefit analysis, the high-risk patients seem to derive the greatest benefit, and perhaps the lower-risk patients may not have received as much benefit. So it is an opportunity to give us some, I think, better guidance in terms of how we may stratify patients with the new guidelines. So let's talk about the top 3 presentations. So I'm going to highlight the BP-HOP trial, and then we'll obviously talk about the barbershop study that came out today. And then finally, I'm going to highlight a little bit about the guideline session that we did. So the BP-HOP trial is actually an initiative at the Brigham and Women's Hospital that's basically cardiologists, endocrinologists, APPs, PharmDs, and it's sort of a pilot program to look at multidisciplinary ways remotely to try to engage in improving blood pressure management. So they use patient navigators, they use PharmDs as well as APPs to monitor and treat the blood pressure based on a very defined algorithm. And basically, they had 130 patients with uncontrolled hypertension based on having at least several readings in the office above 140/90. And they used a Bluetooth-enabled blood pressure cuff that was linked to their Epic electronic health record. So the patients were able to upload the information directly through, it turns out, through software that then allows the information to go directly into Epic. And then those measurements were then reported weekly. And based on whether the readings were high, then they made medication titrations in that trial. And so you can see they had different standards before the new guidelines came out, less than 135/85 for patients under 80, and then less than 145/85. And so they had quite remarkable results. So in this small study of 130 patients, in about 7 weeks, they had 91% of the patients' blood pressures controlled, and their average reduction in blood pressure was 31/18 millimeters of mercury, which is quite impressive. And this just highlights the enrollment. They had several patients drop out. They were relatively young at 59 years of age, and you can see the race distribution. And then if you look at the blood pressure targets that were achieved at only 6 or 7 weeks, you can see that the systolic blood pressure went from 155 to 124, and the diastolic blood pressure went from 92 to 74. So quite impressive results over a very short period of time. And their algorithm included using calcium channel blockers, ACE inhibitors or angiotensin receptor blockers, and in their particular protocol, diuretics were third. And so I think what's unique about this study is that as we move into a world where we're dealing with value-based care and with Medicare imposing these requirements on us through their MIPS program, we're really going to have to use blood pressure as a very important metric in clinical outcomes that are going to really dictate how we're getting paid. So I think this is an example of something that needs to be scaled up, or see whether it's feasible to be scalable, that leverages technology, leverages the fact that we all, unfortunately, are stuck with electronic health records, uses lower cost resources such as PharmDs and APPs to monitor and treat hypertension. The blood pressure trial that we talked about today, the Black Barbershop study, I think got a lot of attention already, and I think going from the one extreme where we use technology, now we have the other extreme. So we have now a population in this study that, there are sort of concerns about ethnic disparities, racial disparities, and this population was treated very differently. So we know that non-Hispanic black men have the highest rate of hypertension-related death. Black men tend to have less physician interaction and lower rates of hypertension treatment, and so there's a need for community outreach. So the original Barber 1 study that was conducted in Texas was sort of extended into this program here in Southern California, difference being that in that study there was no actual pharmacologic intervention, which makes this study perhaps more powerful. So this was just published today, as you all know, by Dr. Victor and his group down in California, and basically enrolled 319 men who were patrons at 50 or so barbershops in Southern California. So the actual geographic range, I think, was 450 square miles. So if you know LA, that's a lot of distance. And they had to have a blood pressure of greater than 140. And so there were two arms. So one was a pharmacist-led intervention who prescribed drug therapy, and the second was an active control group. So essentially, if the patient came in, they had recordings of blood pressures that were elevated, they were encouraged lifestyle modification and suggested to go see their physician to get follow-up for their blood pressure, versus a pharmacist who actually came to the clinic and then basically prescribed medication if their readings were consistently high, and the primary outcome was to look at their blood pressure control rate at 6 months. So I'll just highlight sort of the differences quickly. So what you can see is that the systolic blood pressure were in about 150 range in the intervention and control group, and dropped down to 125 versus 145. So there's about a 22 millimeter reduction compared to the control group in the intervention arm, and the diastolic blood pressure was down by about 15 millimeters of mercury. And you can see that the control rates here highlighted at the bottom, that almost 90% of the patients were able to achieve a blood pressure less than 140/90 in the intervention arm, and even with applying the new standards of less than 130/80, almost 2/3 of the patients achieved their goal blood pressure. And this just shows that there was about a one medication increase per patient in the intervention arm versus the control group. So finally, I'll highlight the session that we ran around the hypertension guidelines. And as I said, Dr. Welton was here and provided, I think, a really great overview of the recommendations and reviewed a lot of the studies to help us understand why the lower blood pressure target was initiated. So some of the key things that came out from that particular talk were that if you look at some of the network analyses and meta-analyses about blood pressure, it's clear that more aggressive blood pressure lowering reduces cardiovascular events by about 20 to 25%. But I think one of the other key things that was highlighted is the fact that even though there was an increase in the recommendation for drug treatment, the overall population is relatively small, so about 2% increase in about 4.2 million adults. And I think the most important thing to emphasize was that I think the guidelines, even though they articulate the importance of treating the blood pressure, the reality is they focused on lifestyle changes and individual management approaches. So that's my last slide. I'm only 5 seconds over. So which of the three highlights that were presented today is most likely to change your clinical practice or impact future research agendas? So hope many of you can weigh in your opinion now. Thank you.
You have to click the slide, I think, to make it go. Okay. There you go.
Okay, sorry. Wow, that's interesting. So the guidelines were the most powerful. I'm surprised that the second, the black barbershop did not sort of seem more impactful. Admittedly, that's a small study that sort of, I think is an opportunity to see if whether it's scalable. But yeah, obviously the guidelines were important.
Thank you so much. I might mention Dr. Yang is the chair of the hypertension work group of the section. So those of you who are going to be joining us in the section and would like to work in the hypertension space, Dr. Yang is your man. So thank you so much, Dr. Yang, for that excellent presentation.
Thank you.
One other comment, and you can. I might also mention that it's not surprising that that they chose session 3. One of the things we've learned at these annual meetings is that a lot of people find the guideline sessions and really clinically oriented sessions to be really most meaningful for their clinical practice. So probably not a big surprise.